Hi everyone! Welcome to our webinar. We want to thank you for giving us your time. April, Allison, and myself are Masters of Science in Occupational Therapy students from the University of Puget Sound, completing this research as a capstone project in collaboration with a community practitioner. This presentation will take about 15 minutes. We will discuss the results of our literature review regarding the effects of both errorless and trial and error teaching strategies for adults with a diagnosis of CVA or cognitive deficit, and how, as a practitioner, you can use this information in your own everyday practice. We conducted this research to answer the following question. Are errorless learning strategies, or trial and error strategies, more effective for adults with a diagnosis of CVA or cognitive deficit when relearning IADL, ADL, and other occupations? Our aim was to address this question in relation to the patient population frequently seen at Swedish Medical Center, while focusing on occupational therapy-based ADL and IADL outcomes. Our goal was to review the current literature on the effects of errorless and trial and error learning to determine whether there could be an evidence-based practice guideline to improve therapeutic outcomes for this population. As other therapeutic professions, such as SLP and PT, may have their own practice guidelines regarding the use of errorless learning or trial and error learning to improve therapeutic outcomes, it is important to begin to establish an evidence-based OT practice guideline which practitioners can cite and use. We defined errorless learning as a method of teaching and learning where the information to be learned is presented in such a way that the learner is prevented from making errors and instead learns from repeated exposure to correct information. This category included learning methods such as functional, experiential training, and implicit knowledge training. In contrast, we defined trial and error learning to broadly encompass all treatment approaches not deemed to be errorless learning, and in which the learner is permitted to make errors. In this approach, the learner benefits from the opportunity to self-correct his or her own mistakes. Based on this definition, trial and error encompasses various types of therapeutic interventions, including but not limited to cognitive didactic training, spaced retrieval, and explicit knowledge training. We began our research by surveying the available literature online and in text. We used a combination of relevant search terms in databases of OT literature, rehab literature, and allied health literature. Our search terms included TBI, CVA, ABI, and cognitive deficit, as these are the main diagnoses with which our collaborator works directly. Errorless learning was also included as a search term, and resulting studies with either errorless learning or both trial and error and errorless learning as treatment methods were included in this review. Our search terms also included outcomes of ADL and IADL as defined in the Occupational Therapy Practice Framework, or OTPF, which are listed above for reference. First, we looked at what each study's results indicated and whether it supports errorless learning, trial and error, both, or neither. After reviewing the resulting studies, we sorted them by targeted outcome area. These outcome areas were based on the definitions of ADL and IADL encompassed in the OTPF on the previous slide. We felt that categorizing these studies by outcome area was the clearest way for practitioners to use this information when addressing specific outcome measures. We will summarize our results first for activities of daily living, and then we'll move on to instrumental activities of daily living. Starting with ADL, results from 3 randomized controlled trials support the exclusive use of errorless learning in improving occupational performance and independence in ADL for patients with an acquired brain injury and dementia. Lee has specifically indicated that errorless learning led to improvements in modified Barthel Index scores for patients with dementia and Trevena-Peters indicated that errorless learning led to improvements in FIM scores for patients with TBI. Additionally, 6 studies with a less rigorous design supported the exclusive use of errorless learning. These studies concluded that errorless learning is effective in improving ADL performance for patients with ABI and dementia. In regards to trial and error learning and ADL outcomes, Mount and coworkers conducted one RCT that supported the exclusive use of trial and error-based learning for improved training of modified dressing techniques for patients with CBA. 2 studies with a rigorous design support the use of both errorless learning and trial and error learning when focusing on ADL outcomes. Vanderplug et al. Found that both studies improved performance of ADL tasks for patients with TBI, while Voigt-Radloff et al. Found that both learning strategies improved functional independence for patients with dementia. Some studies pinpointed population specifics or outcome areas that are especially poignant to the acute care or rehabilitation setting. We have separated these specifics so that practitioners can refer to them when making their decision about which strategy to use based on patient characteristics or outcome measures desired. Vanderplug et al. Found that errorless learning improved independent living scores for patients who were older when compared to other older adults who received trial and error learning. But that trial and error was more effective in improving cognitive FIM scores. Based on this study, if we are working with an older adult with using errorless learning may be a better choice. But when working with a patient who is more cognitively challenged, we may use trial and error learning for improving cognitive FIM scores. This also demonstrates that even within the same study, mixed results were evident when separated by population characteristic or outcome measure. Furland and Urel et al. Indicated that near transfer of trained ADL tasks was improved using errorless learning. Trevena-Peters found that, though not statistically significant, there was a clinically significant decrease in length of stay, agitation, and post-traumatic amnesia in TBI patients. As practitioners, we can use this information to help inform which strategy is used with our patients, allowing the flexibility in strategy based on needs and outcome area being targeted. Here's the bottom line of everything we just presented. With the mixed evidence currently available on the use of errorless learning or trial and error learning for ADL outcomes, there is insufficient evidence to decide that either is superior over the other. Based on the current research evidence, the learning strategy we use with our patient will depend immensely on the person's diagnosis or specific ADL outcome desired. For example, if we have a patient with CVA who has a need for dressing, we may choose to use trial and error based on the evidence provided by the Mount et al. Article. Or perhaps we may choose errorless learning if we are working on improving overall ADL functions for patients diagnosed with TBI or dementia. And that ADL function would be measured by things like the modified Barthel index or the FIM. Now moving on to instrumental activities of daily living results. There are studies which indicate that the sole use of errorless learning can lead to improved outcomes in some IADLs. A single-blinded RCT from Thivierge in 2014 suggested that the use of errorless learning would benefit patients with dementia to improve IADL functions measured by the direct measure of training, or the DMT. Several less vigorously designed studies support the exclusive use of errorless learning in IADL training for patients with dementia and TBI. Deschamps specifically found that the effect of training of IADL tasks was retained more at follow-up with errorless learning. And finally, Cohen et al. Supports the use of errorless learning for improved IADL performance of patients with TBI. In contrast, Owensworth et al. In 2017 showed evidence to support the exclusive use of trial and error-based learning for 25 patients with traumatic brain injury. Studies with a more rigorous design support the use of both trial and error learning and errorless learning to improve ideal performance in patients with dementia and ABI. Lloyd specifically found that errorless learning improved performance on IADL tasks, as measured by a decreased number of errors, more than trial and error learning. However, this varied by type of learner, as those that did not benefit from errorless learning had a decrease in errors as more practice was given using trial and error learning. Similar to the findings for ADL, the effectiveness of both strategies may vary based on patient population, patient factors, performance skills, outcome measures, and setting. Again, we have separated these studies for easier reference, as these studies had population specifics or outcome areas that are especially poignant to the acute care or rehabilitation setting. For instance, Vanderplug et al. Concluded younger participants were more likely to return to work after receiving trial and error-based learning as compared to errorless learning in 2008. Owensworth et al. In 2017 suggested that the use of trial and error learning is more effective than errorless learning strategies for improving meal preparation skills and overall functional independence in IADL for patients with TBI. Cohen found that errorless learning improved social communication skills for TBI patients. Additionally, Lloyd et al. In 2009 found that those who did not benefit from the use of errorless learning methods benefited from trial and error methods to improve IADL performance. Again, here is the bottom line. Similarly to ADL, the mixed evidence currently available on the use of errorless learning or trial and error learning for IADL outcomes, we believe there is insufficient evidence to decide that either is superior over the other. And again, it will depend on the patient we are working with. What does all this information mean for us as practitioners? Well, it means a few important things. One, that in using either trial and error learning or errorless learning, we are not going against what literature indicates as practice guidelines, as there is mixed evidence for the use of both. As we have discussed earlier, due to the current mixed evidence, this means that we can let the evidence inform our clinical judgment based on patient diagnosis and outcome measures desired. The fact that there is mixed evidence indicates that we need to take a closer look at the specifics of the patient we are treating. What outcome areas we are focusing on improving? What diagnosis does this patient have? What is their age? All of these questions will help in guiding our decision-making about the use of errorless learning or trial and error learning. Once we focus on specifics, we can refer to the literature and see which learning strategy is supported. Additionally, asking the family members and collaborating with the patient on what strategy works best for them is an important part of this. Next, we suggest you consult with coworkers and peers. Interprofessional collaboration can be an important guide in our decision-making process when there is mixed evidence to support treatment methods. Ask your colleagues what has worked for them with patients with similar characteristics, what has not worked, etc. Collaborating with coworkers and peers provides a valuable opportunity to gain knowledge on how other professions approach similar problems or practice guidelines in their field. Putting this all together means doing everything that we can in order to provide the best care for our patients. Using evidence-based practice, interprofessional, and patient collaboration, as well as our own experience as therapists, will help us understand when a treatment intervention is or is not appropriate. Now, the final question is, since there is mixed evidence, what can we do as practitioners? Generating research is necessary to help build the body of literature available on these topics. as there is an insufficient amount of literature to determine a practice guideline for our patients. Additionally, in our search, we had a difficult time finding OT literature related to errorless learning and trial and error learning. There are far more numerous studies available within the speech-language pathology literature and other healthcare disciplines. It is therefore important for us, as occupational therapy practitioners, to support our profession through research. We can do this by supplying and supporting case studies, case series, and clinical trials. Attached to our original email is a quick reference for all of the studies included in this webinar. This quick guide can be used as a tool when looking at specific diagnoses or outcome measures being targeted in treatment and what learning method is supported in the literature. It can also be used as a reference in order to look up the original studies found for more detailed information. Thank you for your time, and we hope that watching this has improved your knowledge of the current research base on errorless learning and trial and error learning in regards to ADL and IADL.